Good morning or good afternoon, everyone, and thank you very much for having me along today. I think the topic today can be divided into, of patient safety and risk management, can be divided into so many different topics and areas and broken down. And what I'd actually like to do today is sort of break this down into 3 or 4 different facets, but really looking at the strategies for reducing medication errors and how we're actually achieving clinical effectiveness and how we're actually bringing that clinical effectiveness into the workflow. So along how in combination with those factors are we actually helping at reducing increasing patient safety. Okay. So really when we look at our strategies for effective decision support, and this is sort of one of the areas that we're seeing internationally and pleased to see and hearing through discussions in India, that EMRs and the expansion of EMRs, EHRs in the hospital area is now growing at a faster rate. So where are we actually looking at for some of the strategies that we can look at? So we are really looking at how we are geared to patients and providers. We are making sure that some of the decision pieces that we actually have are part of the workflow, so that we actually want to integrate into the workflow. It becomes second nature, so that as for our clinicians, there's no thought into in what they're actually doing here. We want to have a look at actionable recommendations. We want to have a look at the time and location of decision making and making sure that if we have decisions, we have the tools to give us the right answers at that time. We want to, as I've said before, reduce the burden, if you like, on EMR or workflow for our clinicians and how we're actually capturing the data in the first place. We want to have a look at the justification of the decision support, and all summing up all of this piece is the support for the workflow integration. So at Wolters Kluwer, I think really the main thing here for us to have a look at is, from our clinical health or clinical effectiveness piece, we work in over 40 countries internationally outside the US. We have a number of different solutions here today, but really the main takeaway from this slide is, we have over 1.4 million healthcare providers in over 180 different countries. We look at, or we partner with some of the largest in the EMR, EHR organisations in the world. We look at clinical drug information along with clinical decision support, but we also work directly with patients and patient bodies as well. So how are we actually bringing all of those factors together? So one of the really interesting pieces that we look at around using data is having a look at the Cincinnati Childrens Hospital and a project they actually did in 2000. So we know Cincinnati Childrens Hospital is the third largest leading pediatric hospital in the US. And what they actually did with their cystic fibrosis patients. So as being number 3 in the US, they also found that they were struggling to keep up with, if you like, in some of the leading cystic fibrosis organisations in the US and what they could actually do with that. So one of the key takeaways, and I think it's important to look at, and I'll let you all read that out, but it's sort of really looking at why are we now focused on all of this data. So from an international perspective, and I hope that's sort of now capturing in India, we have got so much data. There is so much data available, but what are we actually doing with this? And how can we actually start to use this data in a smart way? And this is one of the pieces that we're actually looking at today. So what Cincinnati did was they actually took a cut of their data in 2000 and they found that in the 2 main indicators for, in treatment in cystic fibrosis, they were lagging behind, okay? They were behind not only in the national average, but also in the 10 best performing centres and behind in quite a way. So they had a look at what was their median BMI and also what was their median FEV1 scores. So again, they were quite behind in those pieces. So they started to put working groups together and they worked along with the Cystic Fibrosis Foundation to actually start to look at what they can actually do with that. So this is sort of one of the pieces around looking at this data piece that we're trying to have a look at now to highlight patient safety, but then what are some of the factors that we can do around improving patient safety? So we'll actually come back to this in a bit later, but again, it's sort of, this is just one of the examples that we have that, cystic fibrosis is not the only piece that we look at. So again, if we look at arterial fibrillation, okay, so we know it's the most common cardiac arrhythmia. Okay, so we look at different factors in here, and what are some of the treatments that we actually use for CF? What are some of the newer ongoing treatments, and why do we actually have these recommendations in place? But then it's important to look at, you would think that we have strong recommendations, we have new treatment methods. Wouldn't these be, again, used across all our patient groups? And so what the data is actually showing us, that actually 30% of patients do not actually receive appropriate therapy. Again, so, we're looking at different countries here, and again, this was an international study that was pulled across, so it's not just based on the US or any particular country, but this is a global issue that we're actually challenging. Another piece that we had to look at, again, was medication errors. Okay, so we all know that medication errors happen. How frequently do they happen? And again, that sort of changes from different hospitals and different organisations. But if we have a look in the US, for example, so medication errors actually result in the death of 7,000 patients in the US alone, either by wrong medications, by dosing errors, or drug interactions or allergies. So if we break that down, that's 400 lives in every 2 to 3 weeks. So some of the recent figures that actually came out of the Australian market is in Australia annually, okay, we actually waste $12 billion a year on medication errors. Okay, so that's from a small country like Australia, in what we actually waste per year in that as well. So then we're having a look at unwanted variability of care. So if we take two states in the US, so we have a look at New Haven and Boston, and we have a look at coronary bypass surgery. Okay, so what we actually know is that patients in New Haven, okay, are 2 times likely to have coronary bypass surgery. Okay, and then the patients in Boston are likely to have 2 times carotid artery surgery. So again, there's different variabilities just within different countries. Again, looking at prostate cancer. So there's a lot of different pieces that we can actually go into, and I'm not going to go into every one of them. But you can see from the graphs up here that variability of care is also one of the biggest factors that's also implementing on patient safety at the moment. So from the US, in Japan, they have their own factors in here on what's actually going on. So why is this occurring? So we're looking at variations in effective care and patient safety, variations in patient preferences. So again, patients are now more involved in the decision making of their own treatments, and also the variations in supply of sensitive care. The cost of clinical effectiveness is actually $1.2 trillion. Okay, so this is a huge impact that it's having on our society. So when we actually looked at sort of different organisations have put different studies in place to actually look at, well, what are some of the main things, or what's the actual main driver that we can look at to tackle this from a starting point. So reduction in clinical variation is actually being shown to be the number one by healthcare executives, particularly in the US, but now also leading the change in the international market as well. So what is different now? So the cost and quality equation is out of balance, okay? Now, cost and quality equation has reached breaking point, and we're shifting now toward rewarding quality care. Okay, inability to measure outcomes. So we now actually have data or digitisation of these data that can actually, and better tools to help us make better decisions. Our EMRs in the past have been very inflexible. Okay. Now with technology, we have a lot more interoperability or flexibility around our EMRs and what we can use. And just walking around in some of the displays out there today is a really good example of what can be done there. And focus on the physicians alone. So we're actually now seeing that there's a huge change in this, and we're now actually having patients now at the centre of their own treatment. So I'll just quickly cover back off. So what actually happened in Cincinnati was they actually showed that over 2 years, by putting in different factors in here, you can actually see that they improved their median BMI, They're now sitting above the national average, still not performing next to their best performing centres, but they've improved their medium FEV1 scores, which is a huge impact on patients there. So again, leading the national average and almost aligning up in here in the 10 best performing centres. So what did they do? Okay, they really focused on looking at their data outcomes and using data effectively. They looked at standardising their care process, and they empowered families and patients in their own treatment. Okay. So reducing diagnostic errors. So again, this is another study that actually came out of Japan, and it really showed physicians. It took 50 charts from, if you like, physicians that actually had diagnostic tools available versus paper-based charts with nothing available there. And you can see the huge difference there when you actually give someone the tools to make better decisions and help them that are engaged in their integrated workflow, that the actual error rates are actually coming way down. So we'll just quickly get to the end. So this again, what are the factors in decision support? We've had a look and talk through there. Some of the other pieces that we looked at, again, a large hospital in Singapore, how they went ahead and actually looked at putting a process in place that actually gave them a 40% reduction in dosing errors, 31% reduction in their drug-to-drug interactions, but also drug interaction duplication errors were also reduced in there as well. So there are tools and everything available out here. And what are we talking about today is really around how we're transforming healthcare. So we're moving from a model that's had the clinician in the centre, okay, to now realigning everything in our transformation and putting not only the clinician but also the patient and their families in the centre of everything that's being done. Okay, thank you very much for your time.